So the topic of the talk is, so it's a little bit different here than I guess what we have done so far. So I'm talking about the impact of confocal microscopy using congenital heart surgery and how this is the work that we have done over the last, I guess, decade in terms of translating confocal microscopy and using it on. So for today's talk, just to give a brief overview what I'll be covering. So I'll just cover a very brief background and motivation of why we are doing this, and talk how we are utilizing the fiberoptic confocal microscopy for localization of conduction tissue. Then I describe what the FCM system and the dye that we are using for this, and then how we have gone from the clinical translation and safety, sensitivity, and specificity of the system. Then I'll move towards the clinical aspect, where how we have integrated this to the operating room, and then go through some of these cases that we have done, where examples of how we have used intraoperative FCM. And finally, I'll just talk a little bit about the surgeon experience, the feedback that we have got from them, and then conclude for our talk. So just briefly, the problem that we are trying to address is the inability to identify conduction tissue location in congenitally deformed hearts is sort of a leading cause of post-operative conduction abnormalities. And we have hypothesized that by intraoperatively real-time identification of this conduction tissue using FCM will aid surgeons in avoiding these damages and further reduce the rate of post-operative, reduce the rate of conduction abnormalities in the long term. Now, as discussed by Lizzie and Dr. Dewitt and others, there have been a progression of different techniques that have been tried, and some of them are being brought back. I'll focus on the technique that we have been working on, which is identification of conduction tissue based on observed tissue microstructure differences intraoperatively. So most of this work is based on tissue microstructures studies. Based on study reporting tissue microstructure differences reported in immunohistochemical studies performed on cardiac tissues in the nodal and non-nodal or working myocardial regions in mouse heart. In this particular specific study, the first tissues from the nodal and the non-nodal regions were stained with wheat WGA, which is wheat germ agglutinin. WGA binds to the glycoconjugates of the extracellular space and thus highlight the cellular architecture of the tissue. Next, they were also simultaneously stained with alpha-actinin, which is a marker for cardiomyocytes, and they stain equally both the conduction as well as the regular myocardium. And then the third was the same was stained with HCN4, which is a specific ion channel that is used as a marker showing positive only for identifying the conduction or nodal tissues. The study showed that HCN4 positive regions are associated with this reticulated structure as seen here in the middle slide below. Whereas the structure, the microstructure that is associated with working myocardium is more anisotropic. And this is the basic fundamental concept that we use with fiber optic confocal microscopy. The study further showed that these microstructural differences can be reproduced by using a fiber optic confocal microscope, which essentially makes confocal microscope portable and brings it, and we can use it in the OR. So how does confocal microscopy, I guess FCM works in the OR for detecting this? So in FCM, basically, the probe can image at a depth of about 55 to 65 micrometers. Since it's a confocal microscope using a laser, we need a dye, a fluorescent dye to use. The dye basically diffuses through, is applied topically on the endo or epicardium, and it diffuses through to reach depths where you want to image the myocardium. Since we use a hydrophilic dye, it usually stays in the extracellular surface and lights up the boundaries, revealing the microstructure. And thus, using that, we can identify whether the structure that we are seeing under the myocardium as anisotropic or reticulated by an external user. The clinical system that we are using is the Monarchia, developed by Monarchia. It's called the CellVisio 100 series system. It's already FDA approved for use in gastrointestinal, pulmonary, urologic, and endoscopic applications. we are doing an off-label use. The system, we have adapted it to use as a handheld device. We use this Gastroflex UHD mini probe. It's about 3 meters long. It has a field of view about 240 micrometers. So it's a little hard to handle, but the surgeons can do it with training. It has a spatial resolution of 1 microns and can image at a depth of 55 to 65 microns from the surface where it's touched. It consists of the monitor, basically a laser scanning unit, a confocal processor, and a foot switch, where we can. The imaging system, since we are using an FCM laser, we do need a dye. So for this application, we are using an FDA-approved fluorescent dye called sodium fluorescein, commercially available as fluorocide. It has a small molecular size, about 332 daltons. It's hydrophilic in nature. It's non-reactive and non-binding. It is, again, FDA-approved for ophthalmic, urogenital, and gastrointestinal applications. For our case, we have acquired an FDA IND. We use a 1 to 1,000 dilution of the dye, and that is what we see is enough for visualizing the microstructures. We are authorized to use less than 5 ml, but we actually end up using much less. So this is basically the roadmap of how we have come from translating this method from doing it in the mouse, the Langendorf model, then scaling it up to a large animal model by using cardiopulmonary bypass, where we have sort of shifted, where the large animal model mimics gets closer to mimicking the OR conditions. And then finally, we have done some human studies where in 2 phases, starting as a pilot study with enrolling 6 ASD patients, where we just image the known regions of conduction tissue, and just to see if we are able to reliably image the regions and identify the tissue. And then we have followed it up with an effectiveness study, which is called the OPTIMA trial, or the optical tissue identification for myocardial architecture, shortened as OPTIMA, where we have enrolled patients undergoing surgery for ventricular septal defect, tetralogy of Fallot, and AV canal repair, divided into 2 groups as imaging and non-imaging cohorts. We recently finished enrolling the patients for it, and it's still undergoing follow-up. For my presentation, I'll cover some of the cases from these and how these have made differences in the surgical protocol. So coming to just the performance of identification of these tissues for using FCM, when we did the experiments with rodents and sheep, trained reviewers of these images showed high ability of specificity and sensitivity for identifying the conduction tissue versus the working myocardium. But as we move towards the human operating room, we needed to minimize the imaging time and also add a component of reliable classification of the images. So the trained reviewers not just had to identify whether they were able to identify whether there are microstructural differences, but also if the image quality is good enough to do good enough for diagnosing if it's a conduction or a working myocardium. Furthermore, unlike animal studies, in the pilot study, we could not confirm the ground truth through histology. So the way the parameter we used here for assessing the quality of the image classification was by using inter-observer agreement and Fleece's kappa, which basically assesses how if there is agreement between the different reviewers. And in our pilot study, the images acquired in the pilot study gave an inter-observer agreement of 73 to 96.7% with a Fleece's kappa of 0.822, which is by the standard an almost perfect agreement that you need. So here we established that with FCM, we are able to demonstrate that FCM images acquired intraoperatively in the humans can be reliably classified by a trained reviewer. Next, coming into the fluorescein, since we are using a dye with this imaging system, it was important to assess the cardiotoxicity of this dye. Our initial studies were just done on sheep, where we applied different dilutions of the dye on the heart of a beating heart on the ovine heart, and recorded the EKG and the ejection fractions. We did not see any significant difference in variation in the ejection fractions or the PRS and QRS intervals, indicating that fluorescein had no effect on the ventricular function or the conduction system. In our pilot studies, we did record all the adverse events that the patient underwent. All adverse events, events experienced by the subjects were expected for this patient populations, and none of them were associated with the study treatment. And there were no rhythm events that we were recording in this patient. Hence, establishing that FCM using fluorescein dye was safe for use during the congenital heart surgeries. Coming to surgeon training and OR integration, as we moved to the larger trial, we recruited more of the surgeons. The Optima we have eight surgeons trained for using the FCM system in the OR. These surgeons were basically given a benchtop ex vivo, a benchtop setup for learning how to use the FCM system using the probe. In addition, intraoperative assistance was provided by an experienced surgeon, which is Dr. Kaza, who has the most experience with this. We were successfully able to integrate the system into the OR, as shown here on the left-hand side, on the right-hand side here. The FCM system is kept on the left-hand side of the OR table, and the screen is placed directly facing the surgeon. Initially, the idea was for the surgeon himself to use the probe for imaging it and looking at the image and assessing and basically diagnosing whether they're imaging the conduction or the non-conduction or the working myocardium. But we found out it's much easier if there is an assist who can help managing the FCM tower at the same time communicating and interpreting the images for him or her. There was an imaging protocol that we were put in place, basically for doing the FCM imaging. This was done usually right after the patient is the cross clamp is placed and the patient was in bypass, and the primary surgeon exposes the septal defect where they plan to do the imaging after the atriotomy in case of the VSD or AV canal cases, or the ventriculotomy in the tetralogy cases. The surgeon usually then applies the fluorescent dyes, images the regions of interest where they suspect or think is of high risk, which is usually near the crest of where the defect is, near the crest of the ventricular septum where the defect is. On an average, we found that a surgeon took about 4.5 minutes for doing the imaging, with a median of about 3.7 minutes. And we were and used a dye of about 0.2 mLs of dye during the intraoperative. The medium are mostly about 0.1 ml. So as Lizzie pointed out, there is this huge part. We basically wanted to map where the conduction tissue is as they are recording. I mean, for the surgery, they can, once they have recorded, identified there in the OR, they sort of can mark it. But to record this, we developed what's the terminology we used a mapping scheme for the clock phase. A clock phase system. So because one of the purposes of this study was we also wanted to record the deviation in how the conduction tissue localization is varying. And that is where this mapping scheme helps. So here in the VSD case, in one of the VSD case, as you see with the clock phase aligned here, it was the surgeon is actually imaging the probe at close to between 3 and 4 o'clock where they have identified the conduction tissue. And during the surgery, the surgeon would basically communicate what clock phase they are imaging to the assist, who will record and mark if a conduction tissue was detected or if it's regular myocardium. The similar clock phase based on the surgeon's view was developed for the other 2 cases as well that we were included, which is the AV canal and tetralogy flow. In most cases, the conduction tissue more or less lies between the 3 and 4 o'clock, except in the VSD where it's more close to 5 and 6 o'clock. clot phase. Let me go into some of the cases that we have done and show you how we have used and implemented this. So here I'm showing an image mapping in a tetralogy of a case where imaging was performed at 1 o'clock, between 2 and 3 o'clock, 4, 5 o'clock, and 6 o'clock regions. And as you can see, as marked here around the crest, at 1 o'clock region, we saw some reticulated patterns indicating that we should be cautious about or avoid working, sort of putting a suture on that region. So suture, while closing this VSD, the VSD, the suture was placed closer to the crest of the septum near 3 to 6 o'clock, but away at the 1 o'clock position in this particular case. So here is an example of an image mapping case in a VSD patient where the imaging was performed between 4, 5, and 6 o'clock, where you expect the conduction tissue and the node to be. And all three zones near the crest of the septum were marked as, were found, where reticulated images were, pattern was found and marked as unsafe. And in this particular case, these, the patch was so more distal from the crest of the defect. And in this particular case, the surgeon did not, did not change the normal, went about the normal course of the surgical course. But in another patient, there was a deviation in terms of this mapping. And at between 6 and 5 o'clock, the conduction was found to be, the tissue, the image mapping showed that it was safe to operate near the septum at the 6 o'clock. And the surgeon reported to change the course accordingly, modify the course of surgery in this particular case. So based on these, on all the patients that we have done so far, here is sort of putting the mapping scheme. We use the clock phase schematic, to document the location of the conduction tissue regions around these different lesions, and using the clock phase scheme. The tissue type mapping on clock phase schematic during surgical repair, basically in this particular figure, are stacked patient-wise radially, and the clock phase, the green color indicates it's a safe zone for doing anything, and the red zone showing where the conduction tissue was detected. And as you can see, in most of these cases, while prominently the conduction tissue was located between 3 and 4 o'clock, in some of these patients, you can see there is variation in where the conduction tissue can be. So this sort of our FCM system, and as we have been discussing in this whole throughout this conference right now, this is probably the most direct evidence of substantial variability in the location of the conduction tissue region in the heart, and even these simple defects of VSD, AV canal, and tetralogy. On going back to the so we wanted to also get a surgeon's perspective in using this particular device while doing in the OR, and we did this. We did an interim analysis of surgeon where they were provided with this survey in terms of how clear it was for them to differentiate between the nodal and non-nodal tissue. If they had any issues integrating and using the system into the surgical flow, and if there was any level of difficulty in probe use, and also their level of confidence during the operation using this FCM system. So the perspective in general was the FCM use was positive, and more importantly, the surgeon's response indicated more confidence in using FCM during the surgery. There is a little training curve that has been found in terms of using the probe, but I think this can be addressed by giving the surgeons more training preoperatively or even before using these. So with that, I would like to conclude my talk. So intraoperative FCM with fluoroseal dye we found is safe to use, and it's a reliable technique for use during congenital heart surgery. We are able to smoothly integrate FCM into the OR, and able to localize the conduction tissue in a very short amount and reasonable amount of time. We do find that an assist is required at this time until we automate this process, and that's probably where we need to go in the future with this. As one aspect, there is definitely significant variability in the location of conduction tissue regions, and as we have demonstrated, and using FCM by surgeons during these surgery does improve the surgeon confidence in terms of doing this surgery. So with that, I'd like to end my talk.